the mock that was put up on the website. The mock included mainly the extended matching questions, and we will be discussing them. First will be the obstetric part, and then we'll be talking about the gynecological part. Okay. So in the exam, in my exam, I had first there were SBAs with related to obstetrics, followed by EMQs of gynecology. For there was a break in the middle, and after that there were SBA for gynecology and followed by EMQs of obstetrics. So it's put it in. It's the another thing that is there is that like how in our EMQs when we solve in a book or on the app, there are questions that are given, there are options that are given, and then the questions are given in a line, right? In the real exam, it is not like that. In the real exam, they're going to give you, let's say, we have hmm, what let's say we have like something related to contraception, right? They'll give you A, B, C, D, E, F, G, H, I, J, K options, and then they'll just give you one question and you have to select the right answer. Then, after a couple of questions, which will be some different questions, they'll go back to those options, right? So, they are not going to ask you the same questions in the same option list. They will be shuffling the questions, right? They'll go to some other topic and they'll come back to that question again. So, this was something that I was completely not prepared for, right? To switch from thinking about these options and then changing to another question and then coming back to those options after like 3, 4 questions. Are you all understanding what I'm trying to say? Please let me know if you're understanding this, guys. Welcome everyone, those who have joined. And I'm glad that you're joining in and we're listening. We're doing this session today. Even if you are not appearing for the January exam, I would highly recommend you all to still solve the EMQs because EMQs will account for more than 50% of the questions. I'm sorry, they will be accounting for more than 15% of the marks, and also they are difficult to solve. So this is something which is daunting for the students, and that is why I'm taking this session today, especially so that you all are more familiar with these questions. Okay. So let's begin. First, we will be talking about obstetrics. If you all have any questions at any point of time during the meeting, you all please put it in the chat box. Also, if you all have any questions related to the exam, the preparation, any doubts, please feel free to get connected to the backend team or WhatsApp me. If I'm unable to reply, at least get in touch with the backend team so that they make sure that I answer all your queries. Okay. So let's start. First question. First of all, how many of you all have solved the mock on the website? Give me a quick thumbs up if you all have solved the mock on the exam on the website, guys. Yes, Dr. Eman. Have any of you all solved the mock? Please let me know. Extending matching questions are 4 to 5 questions, right? Correct. Okay, you're asking about the marking system, about the questions. I will tell you all about this. Let's first discuss the EMQs. And I understand that like if one goes wrong, does one go out? But that's not, yeah. Yes, yes. Let's solve a question and then we'll talk about it. Or I'll get in touch with you on WhatsApp and we can have a conversation regarding this, Dr. Yaman. Okay. Just ping me a hey on WhatsApp and we'll go about it. Okay. So let's begin. Now the numbers in this are a little, um, I've taken questions from different sources. So I've basically taken screenshots and copy pasted them from other resources. So the question number might be a little haywire, but don't worry. On every slide, I've put the question number up so that you all can understand it. And when you all revise, you all can. It's easier for you all to have a link. Another thing that I want to tell you all is that I have tried to cover most of the high yielding topics which should be read. Like these are definitely to be read before the exam. Okay, like revised before the exam. So first question, these are the options list. So now what happens is for SBAs, it's easier to take an educated guess, right? Because we can eliminate the options. With respect to EMQs, what happens is there are so many options that we get confused, right? So the first best thing that you have to understand for solving EMQs is that when you read the question, I used to never read the options first, right? I used to always read the question first with the knowledge of that particular guideline or talk or scientific impact paper. I used to come up with an answer and see if it is there in the EMQ options. If it is not there, then you have to come up with a second best answer. Okay, so now let's try doing this. I'm not reading the option list. I'm first going to the question directly. The women described below are in labor. For each women select, I'm going to use a pointer so it's easier for you all to follow. Select from above option list single most appropriate action you will take in the management of labor. Each option may be selected once, more than once, or not at all. Now, this is taken from the NICE guideline on intrapartum management of healthy woman and baby. Okay. So, the first question is a 26-year-old nulliparous woman admitted in labor at 4 centimeter dilatation. 4 centimeter dilation. The pregnancy was uncomplicated. After 4 hours, she has progressed to 5 centimeters. So it's a tardy progress. A decision was therefore taken to perform an ARM. 2 hours later, the cervix is still 5 centimeter dilated. So when we do an ARM, the guideline says that you have to reassess after 2 hours. So once we reassess after 2 hours, she's still 5 centimeter dilated. So what is the next best thing that you need to do? Please type in your answers, guys. Read the option list and type in your answers in the chat box. We have almost more than 100 slides to cover. So I want you all to be a little quick so that we can cover maximum as we can and as soon as possible. Okay. Okay, so I'm sorry, I don't know your name. Dr. 44740. Okay, RHR, everything is confusing. So let's see what are our options. It is H epidural, commence syntocinon, and your R is syntocinon and re-examine in 2 hours. Okay, so the correct answer for I'm gonna write the correct answer in at the beside the question. The correct answer for this is H. Okay. And why is that? According to the guideline, I have also taken a screenshot of the guideline. Uh, Um, so first, let's solve the questions ahead and then discuss the guideline, right? If it's correct, it's wrong, it's fine. Just give me a moment. We'll go through the slide and then I'll talk about it. Okay. Next question. A primary gravida has been diagnosed as having slow progress in labor at 4 centimeter dilatation. She was admitted 4 hours ago, have started contracting at home 2 hours after rupturing her membranes. An epidural has been cited and syntocinon has been commenced, right? So what would we do? After commencing syntocinon, what would we do? So if once we start the oxytocin or the syntocinon, they've said, what for anything to do, before we do anything ahead, we will have to do something. Okay, Dr. Chetty is saying N. Okay. Okay, there are again mixed answers. Doctor says re-examine in 1 hour and another one is re-examine in 4 hours. Syntocinon and re-examine in 4 hours. So you all are correct with this regard that you have to examine the patient after 4 hours. So the correct answer here is N because it's simple. According to the guideline, we have to, if there is, you have to, if she's in labor, you do a PV and after 4 hours, she's not dilated more than 2 centimeters. We have to either consider an ARM. Now, after doing an ARM, we re-examine after 2 hours. Even if she's dilated less than 1 centimeter or 1 centimeter only, we can consider doing augmentation of labor using syntocinon. And in this, after we start syntocinon, we do not need to examine her in 2 hours. The guideline says you examine her in 4 hours. So the correct answer is re-examine her in 4 hours. A 30-year-old primigravida went into spontaneous labor and was diagnosed at 41.3 weeks. She was diagnosed with failure to progress a 5 centimeter dilatation. Syntocinon was commenced, and 4 hours later, she is now 6 centimeters dilated. The fetal heart rate is normal, and the presenting part is at the level of the spines. So, out of all of this, what is the best that you can do? Okay, okay. So again, mixed answers here, guys. So you have to remember for this exam. In reality, I would have answered if somebody asked me today in my clinical practice what I would do. I would say yes, I would re-examine her in 2 hours, right? Because she's contracting well. Her fetal heart pattern or the tracing, the CTG is normal, but the guideline says that if she is even after 4 hours is started and she has just dilated 1 centimeter, that is basically non-progressive labor for them, and they suggest doing suggest that you have to consider doing emergency LSCS. So they're not saying you do it; you have to consider the like you offer the woman emergency LSCS and discuss with her. So it's basically E. It's E because it's a maternal indication. The fetus is fine. That is why they've given the line that the fetal tracing is fine. Okay. So let's look at this is a little difficult. Okay. So labor was something that even I found difficult. But don't worry, as we keep on solving the question, we will be able to understand and get a hang of the EMQs. Now, first, let's look at the answers. Now, as I said, she is 4 centimeters dilated, and we did an ARM. After ARM, she is only 5 centimeter dilated. So here, the guideline says that when there is a delay in labor or it is slow, we can do a rupture of membrane. After doing rupture of membrane, the woman has to be examined for within 2 hours. And if it is less than 1 centimeter, then syntocinon should be commenced. And before giving syntocinon, it is advisable to offer the woman an epidural. Okay, this is a screenshot from the guideline. When do we establish a delay? A delay is established when the cervical dilatation of less than 2 centimeter in 4 hours of first laborers, that is primigravidas, cervical dilatation of less than 2 centimeter in 4 hours, or a slowing in the progress of labor for second or subsequent laborers, descent and rotation of baby's head, changes in the strength, duration, and frequency of uterine contraction. All of these are used to assess the delay in the first stage. Now, after this has happened, advise all women with suspected delay in the established first stage of labor to have a vaginal examination 2 hours later and diagnose delay if progress is less than 1 centimeter. This is for the cesarean section, right? So my first answer was H, epidural and commence syntocinon. I hope this is clear, guys. Labor is a little difficult to understand, it might be confusing, but if you open the NICE guideline and go through it, it is given in clear words as to what you have to do. If you are getting confused, my trick here would be take a piece of paper and just make a table out of it. Like after, if you all want, I can help you all, I'll just share it by let's say Saturday. I will make a flashcard on this labor guideline because I think it is very important and it is also difficult to remember because in clinical practice, it is something else that we follow. Okay, guys. But for your self study, if you are interested to do it on your own, please do it because that can help you in last minute revision. Okay, the next one is once the syntocinon is started. Advise women who has been commenced on syntocinon to correct dysfunction labor is examined 4 hours after commencing the oxytocin. And you have to increase it. The increment is not at more than 30 minutes. And you have to keep on increasing till you at least get 4 to 5 contraction in 10 minutes. Okay. This is again clearly stated in the guideline. Okay. So this we've read after amniotomy, vaginal examination done after 2 hours. If no progress after 2 hours, diagnose delay, transfer to obstetrician-led unit, and you have to do a full assessment. And you can also consider starting oxytocin. Advise the woman to have vaginal examination after 4 hours of oxytocin, not 2 hours. Okay. In our clinical practice, we may be following 2 hours, but it is not 2 hours. You have to re-examine her after 4 hours. And after 4 hours, if the cervical dilatation has increased by less than 2 centimeters after 4 hours of oxytocin, further obstetric review is needed to assess whether a cesarean birth is advisable. So this is the best answer for the last question, the cesarean. Okay, now you all must be confused. There are so many cesareans here, right? So this knowledge is extra from the nice cesarean categories, right? I have taught you all in your sessions. We have category 1, 2, 3. 1 is within 30 minutes. I think the next one is 70 or 75 minutes. And then 3 is, it is as per the convenience. And here, as you know, that the fetal heart tracing is normal, we go in for a maternal indication, okay? Are you all clear so far, guys? Is this way of discussing the questions okay with you all? Give me a quick thumbs up and then we'll move on to the further questions. Guys, please waiting for your thumbs up. Yes. Okay. Yes. The DSS. Yes. So this is taken from Justin Conje, the EMQ paper. Now this was the older guideline because this is 2014, updated 2016. However, these screenshots that I've put in, if you could see it properly, amended 2023. Okay. They are from the latest guideline. Okay. Next question, guys. Yes. Thank you. So let's move on to the next questions. Read the first question. I'm not reading it with you all. You all have to read it on your own, like you all would in an exam, and put in the answer, guys. The first question. So first question we are answering first. Yeah, go step by step. I will answer. I will discuss each question, and then we can tackle the next one. Okay. So first is answer is Q. Okay, Dr. Paul. Dr. Manikam has said we. Okay. So here the correct answer is actually we, because we have to offer her an option between vaginal progesterone or prophylactic cervical cerclage. Okay. Again, I'm stressing, guys, you have to answer according to the guideline, not according to what we practice in our real life. Because yes, even I would have answered as Q because that is what we would offer the patient. But the guideline says that you have to either offer her a vaginal progesterone or cervical cerclage, and depending on the decision she takes, you have to do whatever, like follow her decision. Next is, please answer the next question, guys. This one's easy. I think all of you will get this right. Okay. Dr. Manikam, Dr. Hosni, Dr. Paul has not answered yet. I'm waiting for a little more answers. Yes. Okay. So this was easy. You are correct. It's you, vaginal progesterone. Here, this is a primigravida, right? In primigravidas, only if there is a cervical length that is less than 20 or 20 or less than 20 in primigravidas who do not have any history basically of previous preterm births, you do not offer cervical cerclage or even an option. You just give them vaginal progesterone. Okay. Now next question, guys. This is also pretty easy. So we have a lot of people today. So guys, please answer actively. Even if you are wrong, it's fine because this is an excellent opportunity to be an active learner. Okay. So please answer and don't feel shy. No one really knows who you all are. So it's fine. Nobody's gonna judge you for answering wrong, but active participation is, it's you start thinking when you answer, and when you actively learn, you retain better. Okay. Yeah. So I'm happy most of you all have answered correct. The correct answer here is cervical cerclage. Okay. So let's look at the answers. I'm going to show you all directly the screenshots. Okay. Now here we knew that she had a loss in her 30 weeks. Okay. And in this pregnancy, she has a short cervix, right? So this is the guideline. They say that offer a choice of prophylactic vaginal progesterone or prophylactic cervical cerclage to women who have both a history of spontaneous preterm birth or loss from 16 weeks of pregnancy onwards, and also having a transvaginal scan between 16 to 24 weeks showing a length that is less than 25 millimeters. Discuss the risks and benefits of both with the woman and make a shared decision on which treatment is most suitable. Right? Latest guideline. So the correct answer here is vaginal progesterone and prophylactic cervical cerclage. The next one was the primigravida who had a short cervix on USG. So this is again the same thing, that consider prophylactic. Oh, sorry, this is not the correct one. Yeah, so this is consider vaginal progesterone when it is between 16 to 24 weeks of gestation. She is less than 25 millimeters, and however, she has no history of spontaneous preterm birth or mid-trimester miscarriage. Because if she did have a history, she would have come into this category, right? Then next is any women. So this is what I wanted to tell you all. Consider prophylactic cervical cerclage for women when results of transvaginal ultrasound carried out between 16 to 24 weeks of pregnancy show a cervical length of less than 25 millimeters or less, who have either preterm prelabor rupture of membrane in a previous pregnancy or a history of cervical trauma. So this question beautifully revises the guideline for you guys, that where you're going to offer her only prophylactic cerclage, where only you're going to offer her vaginal progesterone, and where you're offering her an option. Okay. So the nice guideline is saying that only and only when she has a history of either cervical trauma, which includes previous cone biopsy, large loop excision of transformation zone, or radical diathermy, or if she has a preterm prelabor rupture of membrane, okay, PPROM, in her previous pregnancy, and not losses. The losses would be coming under this category. Okay, guys, I hope you all are clear. This question is beautifully summarizing this important aspect of the guideline. If you have any questions, please put it in the chat box, or we'll move on to the next one. Okay. This is with respect to the RH isoimmunization guideline. The Green Top guideline has been archived, and now it's the British Society guideline that we follow. So first, let's answer the seventh question. Okay. Hello, Dr. Ruby. Okay. Uh, Dr. 44740. Please tell me your name so that I can talk to you all with your names. Okay. Dr. Manikam is saying B. Dr. Faria is saying A. Okay. Hi, Dr. Pradeep. Okay. Dr. Chetty A. Dr. Paul, why C? So this is why I've put this question, because they say that after 20 weeks, we definitely give the higher dose. You're right with that aspect, 500 international unit of anti-D. But this guideline says that you also have to do the the fetal-maternal hemorrhage test. Okay. So the correct answer here is B, guys. Yes. Before 20 weeks, we give the lesser dose. Okay. Very good. I'm glad you all are able to. So this is what you all have. You all have a confusion, and this question has cleared that confusion for you all, right? We've revised the guideline by solving this question. Okay, please move on to the next question, guys. Okay, Dr. Manikam, Dr. Ruby says F. Waiting for more replies, guys. Dr. Hosni is also F. Dr. Pradeep is saying E. And Dr. DSS is saying C. Okay. So let's look at this question, right? A 30-year-old rhesus negative woman has a threatened miscarriage at 14 weeks of gestation in her first pregnancy. An anti-D prophylaxis is administered. Bleeding continues 3 days later, but then stops. And once again, 1 week later. Okay. So the correct answer here is F, because when a woman has repeated bleeding, right, the guideline says that if she has repeated bleeding, then you will have to give her at 6 weekly intervals. So in this, and she's more than 12 weeks. Okay. So in women who are between 12 to 20 weeks and with repeated bleeding, you give 250 international unit, 6 weekly intervals. So the correct answer is F. Okay. This is given in the guideline. You all can go back and read this up. I'm not sure if I've put a screenshot for this, but yeah, that is why this was a googly question that I wanted you all to answer, because repeated bleeding after from 20 to 20 weeks, you have to give 250 international unit at 6 weekly interval. Okay. So, next question, guys. Okay. Dr. Husni and Dr. Manikam have answered E, that no anti-D required. But I'm going to ask you all a question for this, is that, so we consider that the fetal-maternal hemorrhage occurs during birth, right? And she doesn't want to have any further pregnancies. But do you think that fetal-maternal hemorrhage also occurs during pregnancy, during she's pregnant? Does a sensitizing event occur when she's pregnant as well? And can antibodies develop and cross the placenta and affect the baby? This is also a very beautiful question. Okay, unfortunately, guys, most of you all have gotten it wrong. The correct answer here is J. Correct, Dr. Ruby. I'm so happy. You've answered correct. The correct answer here is check antibody screening at booking and at 28 weeks. I gave you all a big hint by saying that does fetal-maternal hemorrhage also occur during pregnancy? To first of all, please answer my question. Does fetal-maternal hemorrhage occur during pregnancy? Give me a yes or a no. Sensitizing events can be anything. It can happen in the third trimester as well, right? So here the answer is J. Okay, now let's don't worry if you'll have gotten it wrong. You all can correct and actively learn this right now as well. In this following 1 minute, you all will be following 1 or 2 minutes. You will be able to actively remember that okay, yes, I went wrong here, and now okay, this is the correct thing, and I will remember this for my exam. Okay, let's discuss the last question, guys. This is again taken off from the guideline. Beautiful question. Okay, Dr. Ruby says G. Dr. Faria, good. C. Dr. Faria, Dr. Husni, G. Yes, yes. Very good, guys. You all are correct for this. It's an easy one. When cross-matched, when a rhesus positive is transfused, and if it's more than 15 ml, you have to give large doses. Okay. So let's look at the answers now. So the first answer was, what was the question? Yeah. So fetal loss at 21 weeks. So anything about 20 weeks of gestation, you have to give a minimum dose of 500 international unit and occurred within, it should usually be given between 72 hours. Maximum you can give it up to 10 days. And this is the clincher here, guys. Please, please, please remember this. A test of fetal-maternal hemorrhage is required, okay? Then next is 6 weekly intervals. D-negative women presenting with continual uterine bleeding between 12 to 20 weeks of gestation should be given at least 20 international unit anti-D at a minimum 6 weekly interval. Now, this is what I was talking about. This is the special question that I want to talk about. So even if she says that I want to get sterilized, she can still have the fetal-maternal hemorrhage in this pregnancy, right? So it is very important that you check antibody screen at booking and at 28 weeks. Okay, she can become ICT positive, and we can have to. Therefore, it might our management might change for the pregnancy if she becomes positive, right? So, maternal alloimmunization can still occur even when there has been no recognized sensitizing event. This is thought to be due to a silent FMH that can occur. Routine antenatal prophylaxis was introduced to try to combat such effects, and there is evidence that routine prophylaxis does reduce the incidence, and that is why it has been introduced into the antenatal care pathway. However, some women will decline RAADP, and women should be counseled with regarding to risks and benefits so that an informed decision can be made. In such cases, the antibody screen should be checked at booking and 28 weeks to look for any sensitizing events. So in the latest guideline, what they've also said is that you have to take a consent. You have to take consent for administering it also, and you have to take a consent even if she is declining the RAADP. Okay, clear so far, guys? Next, simple, you all were right. You all have to give large dose. When less than 15 ml has been transfused, the appropriate dose give depending upon the test that we do, the FMH test. And however, if it is more than 15 ml, we have to give larger doses like 1500 to 2500 international unit dose. IV anti-D is the preparation of choice, which is so IV achieves the plasma levels faster than IM. IM only preparation should never be given IV. Okay, this is taken out of the guideline. I've copy pasted this here for your review. Okay. I'm glad you all are doing well, guys. I'm not sure how many of you are appearing for this exam or not, but it's still I'm happy that you're able to answer and understand how to solve EMQs. It's a trick to solve this. You have to think what is given in the guideline. Don't think that what you will do as a clinician, but go back and start think to like try to remember the guideline. Okay. Next question, guys.
Again, this guideline is here because there's an update in 2024. The chickenpox guideline has been updated. That is why it's here today for you all to answer. Because I think it's a definite question. Good. You're answering right. So the new guideline says that you have to administer a cyclovir as post-exposure prophylaxis between 7 to 14 days of exposure. You're right. Okay, so this correct answer here is G. Move on to the next question. So here the clincher is shingles. Hello, Dr. Bhavna. H. C. Don't guess, guys. It's okay if you're wrong. I still remember I used to be petrified of solving EMQs. Okay, C. Most of y'all are saying C and y'all are right because shingles is not associated with a barrel. Dr. Faria, it's fine. You know, I that used to happen with me as well, and I used to get so frustrated. But that is when changed my thinking, saying that no, even if it's wrong, I'm actively learning what is the right answer. Because if this question on similar terms comes in your exam, you will be able to answer it. Because, you know, this is exactly what used to happen to me. And I was so frustrated with it. And that was one of the main reasons why I wanted to do this EMQ workshop. So when we were coming up with the program schedule, I told the backend team, like, no, this is something that I want to put and I want to do it because EMQs is something everybody is scared of. Okay. But it can be a pointer, a scorer, if you all are able to get into the limbo of trying to solve it. Okay. So correct. 12 is C. Last question, guys. So here the clincher. Every word, every question has a clincher. Rash is 3 days post delivery. That's your clincher. Okay, I'm happy you all are correct. Yes. See, Faria, you were correct. So you are answering correct. I'm going to heart it for you. Okay, so let's go to the question discussion, answer discussion. So the first is the update. So here is the big update word that I've put. And please, please, please screenshot this and keep it in your review folder for a few days before reviewing. Uh, if the pregnant woman is not immune to varicella zoster virus and she's had a significant exposure, she should be offered PEP in the form of oral antiviral therapy like acyclovir or valacyclovir. And this should be done from day 7 to day 14 post exposure. However, if there's some contraindication for antivirals, then only we would give varicella zoster immunoglobulin. Okay. Varicella zoster is, so this point is the same as before. VZIG is effective up to 10 days after contact. And once you give varicella zoster immunoglobulin, the patient has to be considered infectious for 8 to 28 days. And if she does not have immunoglobulin given to her, she should be considered um, what do you say, infective for 8 to 21 days. So how I remembered this was that when you give something, she's infectious longer. When you don't give her anything, she's not infectious longer, right? So if you give, even though immunoglobulin is given, it can be, she's still infectious till 28 days. So just remember this. I used to remember it as given, so it's longer. Thank you, Dr. Ruby. Okay, let's move on to the next question. Um, so maternal shingles is something that should not really be stressful because it's a secondary infection, right? So in the secondary infection, uh, the woman will already pass on the antibodies to the baby. So the baby should not have an issue. However, if the baby is born before 28 weeks or is less than 1 kg, then you can consider giving immunoglobulin with or without acyclovir. And the last answer, most of you all were correct because um, if this is the clincher here, this is the important thing. If the maternal infection occurs 1 to 4 weeks before delivery, up to 50% babies are infected and approximately 23%. Again, important numbers. You all have to remember this. 1 to 4 weeks, 50% babies, 23% will develop clinical varicella despite high titers of passively acquired maternal antibody. Severe chickenpox is most likely to occur if the infant is born within 7 days of onset of mother's rash. So here, what do we have to give? We have to give varicella zoster with or without acyclovir. Okay. There is no need to test in these circumstances if it is within 7 days before or after delivery. Okay, please remember, guys, this is important point. Okay, moving on now. Next question. We are answering question number 14 to 16. Now, this is then something that you all have to know. This has to be on the tip of your, tip of your tongues because venous thromboembolism is something that they will 110% ask you. There could be two EMQs because there are two guidelines, right? There's management and there is prophylaxis. I still love solving the LMWH questions because they were like math. I've said this in my session as well, that once you know the table, you can just do the math and get the correct answer. So first, let's answer question 14. Again, the clincher here, guys, is antithrombin 3 deficiency. That is the clincher. Dr. Manikam, Dr. Ruby says C. Dr. Pradeep, Dr. Faria says B. So in the guideline, guys, I'm giving you a hint. Do you all remember there were certain conditions wherein we give high dose of LMWH? There's a normal prophylactic dose and there's a higher dose. These conditions are where we give higher dose. So antithrombin 3 deficiency is wherein we would want to give her a higher dose of LMWH. So the correct answer here is C. And you have to involve hematologists in the care. So the correct answer is C. I will show you all the table so you all will be able to recollect the guideline. So every question has a clincher word. You have to bank on it and write and come up with the correct answer. Let's solve the next question, guys. I'm hoping you all are understanding and following. This could be a bit of a long session, but I'll try to cover as much as I can and as fast as I can because we have a lot of slides to go. The clincher word here is a previous history of DVT and no obvious inherited thrombophilia. Okay, so I'm going to revise something with you all right now. When the score is 4, okay, equal to or greater than 4, we begin thromboprophylaxis immediately from the first trimester and you continue it for 6 weeks. If the score is 3, you consider thromboprophylaxis for 28 weeks. If the score is equal to or more than 2, you consider thromboprophylaxis at least 10 days postnatally. Okay. So here, a previous history of DVT falls in a score of, I'm going to show you all the table here, guys. Okay. what would the score be? And then what would the answer be? Here you have to look at the words very carefully that have been given in the table. They've said that previous VT except a single event related to major surgery. Okay. And that is 4. And previous VT provoked by major surgery. Now here I will also show you all the next table. So only this group requires high dose. And they have said previous VT, but on long-term oral anticoagulant therapy. Have they said in the question, Dr. Ruby, that she is taking anticoagulation before pregnancy? They have not. They have just given us any previous VTA, right? So she comes under the high-risk group. So here you just recommend antenatal and 6 weeks postnatal LMWH. This is the category. Are you all following, guys? I want you all to learn. Please do not feel down that you all are getting it wrong. Please learn. Okay. So this correct answer is B. Yes, it's B. Next question. So this woman, this is the score that you have to calculate, right? This is the 3 and the 4 and the 2 that you all have to do. Okay. Dr. Husni is saying J. Dr. Mehreen, there's no 3 in the... I'm sorry. Please answer correct. It's Dr. Manikam is saying B. Okay, Dr. Manikam, anyone, please tell me what is the score? What is the score that you all have calculated according to the table?
Now 3.
Yes, you all have answered 3. So for 3, what do we do? Do we start antenatally from 6 weeks or from 28 weeks?
Yeah, yes, ma'am.
Yes, from 28 weeks. So yes, you all are correct, guys. It's J. Okay.
Not B, ma'am.
No. So
Mm.
if
From
you go
28,
to,
but
yeah, from
any receiving from 28 weeks will have postnatal 6 weeks also.
yeah, but then here it is antenatal LMWH and 6 weeks postnatal. They have
Yeah,
not mentioned the,
Mm.
like if they would have given antenatal 28 weeks, I would have taken this as the answer. But if
Yeah.
they're just saying antenatal LMWH, that means they're just starting it right now, right? At whatever age. And they have given her 12 weeks, right? In the question.
Okay.
Yeah. Okay.
Yeah.
But it's a good question. So I'm glad you asked me that, ma'am. So we start from 28 weeks and not at 12 weeks. That is why that answer would be wrong. Okay. So I think most of you all have answered this very well. And I really want you all to have a screenshot of this table in your revision notes, a screenshot of this and a screenshot of this. Okay. If you all want, I'll wait for a couple of minutes so that you all can make a note of this, because this is something that you have to see before you go to your exam. Okay, because venous thromboembolism is 110% sure question. There is not a single exam in which they've not asked this. And can you tell me why is the reason why they ask VT so much in the exam? Any guesses? Yes, Dr. Ruby, you're right. The most recent MBAS report is saying that the most common cause of death in women, in pregnant women in the UK uh, is venous thromboembolism, COVID-19, and cardiac disorders. Okay, for the last 2 years, 2022, 23, and 24. Okay, great. So this, please take a screenshot. This you'll already have in the guideline because this is not going to be zoomed here. And another thing I want you all to remember, guys, is the BMI. Okay, the BMI category is also different, and the BMI score is also different. Okay, the BMI score is 1 for 30 and 2 for 40. The BMI being 40. Okay, and this is also something very important because this is highlighting the high dose. What is wrong with my pen? Next question, guys. This is again a guideline on the management of venous thromboembolism. Do you all want me to zoom in? Okay. I'm going to give you all a hint here. And the hint here is that she has symptoms of DVT. Okay. You're right. I'm happy you're right. It's D. Because here she has symptoms of DVT, and the DVT could be a cause of the pulmonary embolism. So what they're saying is that if the patient is showing symptoms of deep venous thrombosis, you do a duplex ultrasound. You can even start her on LMWH, and you can do a duplex ultrasound. If it's positive, you do not need to test her further by doing a VQ scan or a CTPA, because we know that she already has a thrombosis, so we can suspect that that is the cause, and you just start immediately. If, however, the duplex is not normal, but there's a high clinical suspicion, you can continue it and repeat the scan. I will tell you all about this ahead. Please answer the next question, guys. Okay. Dr. Manikam, Dr. Hosni has said C. I'm waiting for a couple of more replies. Dr. Chetty says F. Dr. Chetty, I'm going to give you a hint. The question says that there are no signs and symptoms of DVT. And it is pointing more towards a pulmonary embolism. Okay, so the correct answer here is C. So what does the guideline say? The guideline says that when there are no signs and symptoms of DVT, instead of going for the duplex, or even if the duplex is, we don't see any signs and symptoms, what we need to do is we have to do a chest X-ray followed by either a ventilation PQ scan, that is a ventilation perfusion scan, or a CTPA. Okay. Now, next question. I'm so happy you are answering this so well. Dr. Ruby, so this is one point that I want to highlight here today. And when there's a history of breast cancer and you're suspecting a DVT, we go in for a VQ scan. Okay. Why do we go for a VQ scan? Because compared to I'll discuss this. I'll just tell you all this. Why do we go for a VQ scan? So the correct answer here is B. Okay. Dr. Ruby, please make a note. Yes, ma'am, VQ causes breast CA. No, it will have, it has lesser amount So yeah, that's the thing I'll show you. Just give me a minute. So I'll show you the screenshot. Right. Women with suspected PE should be advised that compared to CTPA, VQ scanning may carry a slightly increased risk of childhood cancer, but it is associated with a lower risk of maternal breast cancer. In both situations, the absolute risk is very small. Okay, please read this question again. Read the sentence again. Yes. So here they're saying that it can cause childhood cancer to the fetus, okay, maybe. But for the maternal breast tissue, it is lesser. So remember, maternal breast is VQ. Okay. And when the X-ray, oh, then I have a next question, so I'm not going to ask you all this. So first, this is clear. Even a women with suspected PV who have signs and symptoms of DVT, compression duplex ultrasound should be performed. Chest X-ray followed by VQ in a patient with suspected PE without symptoms and signs of DVT. A VQ scan or a computerized tomography, pulmonary angiography can be done after a chest X-ray. Where the chest X-ray is, this I'm not answering. You all have a question for this, so I'm just going to skim through. Next question. When, but the chest X-ray is normal. So when the chest X-ray is normal, what do you do? You all are getting confused. They're asking that the chest X-ray is normal, not abnormal. Okay. So the correct answer here is E. Because when they say that the chest X-ray is abnormal, they prefer doing a VQ scan. I'll show you all the screenshot of the guideline. Please answer the next question, guys. Yes, abnormal CTPA, correct. They have said the X-ray is normal here, guys. Yeah. So this is, let's discuss it. It's okay. You'll answer the next question. We'll discuss this question properly. Okay. Dr. Ruby, Dr. Husnain says H. Okay. This is an easy question, guys. They have hinters, 95, and second DVT in the last 5 years. Correct. You're right. Here the answer is H. So I'm going to show you the screenshot. When the chest X-ray is abnormal and there is clinical suspicion of PE, you have to do CTPA. So you remember ABC, right? Abnormal, you do ABC. I'm sorry, this is really bad, but yeah, abnormal chest X-ray, you do a CTPA. Okay. And for the next question, when do we do a factor 10A level, anti-10A level? These are the scenarios when the body weight is more than 90 kg or less than 50 kg, recurrent thromboembolism or a renal impairment may alter the effectiveness, and that is why we do factor 10A. Okay, anti-10A levels. On factor 10A, anti-10A levels. Correct? Most of you have answered this well. Mm, this is, I've already told all about this. Yeah. I'm sorry about the markings on this, but the one which the PDF that I had these markings and I was unable to remove them. Dr. Ruby, don't go with the markings, please. Look at the question properly again. You have to select for that particular patient. She has done her booking visit. Dr. Paul, hello. You're saying D. Dr. Pradeep is saying C. Again, Dr. Pradeep, the same hint for you. Please look at her. She's already had her first antenatal visit. Okay, I will zoom in. You want me to zoom in on the question or the options, please? Question, okay. Is this okay now, Dr. Merin? Please let me know whenever it's not visible. Just kindly let me know that I have to zoom in so I can zoom in for you. Okay, so the most of the answers are either C or D. And the correct answer here is D because she has already had her first visit. So the guideline says, the HIV guideline says that you have to screen for her health now, for the depression now, then at 4 to 6 weeks, and again at 3 to 4 months postpartum. You will find this at the beginning of the Viva guideline. Okay. Next question. I'm so sorry, this question is incomplete. I'm going to put that for you all. It says, a 25-year-old woman booked for antenatal care at 10 weeks of gestation 3 months ago and was screened positive for HIV. She is screened for sexually transmitted STI, counsel, and baseline investigations were sent. However, she is not willing to inform her partner that she is HIV positive. So, in this case, what would you do? Dr. Pradeep says E. Dr. Paul is also saying E. Dr. Manikam, Dr. Ruby, okay. Dr. Husni says E as well. Okay. You're all right. You'll have to break confidentiality in such a case. Okay. So here, this is assess for depression now, 4 to 6 weeks and 3 to 4 weeks. Okay. And this is break confidentiality. Confidence in telling others about HIV will vary from woman to woman, and there may be cultural factors, other factors about telling them. But this can give rise to complex professional, ethical, moral, and potentially legal situations. Breaking confidentiality in order to inform a sexual partner of the index patient a positive HIV status is sanctioned as a last resort by the WHO and the GMC. Okay. Next question, guys. Question number 24 and 25. We're halfway done through obstetrics. Oh God, it's going to be a long session, guys. Come on, we can do this. This is PPH. Yeah. This is about the PPH guideline. Again, I think something that is very high yield. You'll have to read this and know the guide. You'll have to know the, what do you say, the algorithm. Question number 24, please. Okay, so you're all right. P is the correct answer. Let's answer the next question.
Hmm?
Okay, you all are answering E and you all are right. It's examination under anesthesia. I'm very happy you all were right. This is that PPH algorithm. I'm sorry for the bad picture and I'm going to zoom it in. So first, major obstetric hemorrhage, major blood loss greater than 1000 ml or continuing major obstetric hemorrhage. Senior midwife, obstetrician and anesthetist, alert hematologist, alert blood transfusion lab and do the ABCD. This is also another question, fluid balance that you can give. You can give maximum 3.5 in which 2 liters is isotonic and 1.5 is colloid. Blood transfusion has to be like you start. Another important thing is 14 gauge major obstetric hemorrhage, 14 gauge of cannula, like you have to put two at least. Send all the examinations, put a Foley's catheter. Why? Because you have to empty the bladder. And the first step is rub up the uterine fundus. And this is how you have to follow. So this is something that I want you all to screenshot, but because first you rub up the fundus, you empty the bladder, you give 5 international units slow IV, repeat if necessary. Ergometrin 0.5 mg slow IV or IM. Oxytocin infusion 40 international unit and 500 ml. Carbopro 0.25 mg, you can give every 15 minutes, maximum 8 doses. Carboprost intramyometril 0.5 mg, misoprostol 800 micrograms sublingually. Consider tranexamic acid 1 gram IV. This is very important, okay? And then you go to the theater. Dr. Husni, this is managed in the theater. So examination under anesthesia. Okay, I hope this answers your question. So everything is from all the data that we have with us. Okay, so just go through this algorithm. Another high thing, screenshot. This has to be a must see before your exam. Okay. So moving ahead, next question. Why is this okay? Yeah. So this is another updated question. I'm sorry. The update should have been in the answer part. There's an updated guideline on this. Another, I think, oh, they'll obviously put a question from this because it's been updated in 2024. Please answer question 26. Here the clinch of guys. Have you all read the latest guideline on this? Or okay, Dr. Chetty says N. Dr. Husni says O. They have a beautiful table in the new guideline. And I want you all to take a screenshot of that and remember that. Correct answer here, guys, is N. We will discuss both questions together. So please solve the next one and then I'll have a discussion.
You all can't see my screen. You all can see my screen, right? No? Oh, share. Just a minute. Something must have gone wrong. Give me a minute, guys. Give me a minute, please. I'll reshare it. Is it visible now? Okay, great. Sorry about that. I'm sorry, 26 only. I'm not sure. K is serial ultrasound. No, the correct answer here is amniocentesis. A. Let's discuss this, okay? So this is the latest guideline. It's been updated, and we so in high risk population, so they have a classification, right? They have high risk, moderate risk, and low risk. In high risk, what was our high risk? Echogenic bowel. It sits right here, right? In the high risk. In this, what do? Even one factor is present. You consider prescribing aspirin 150. I'm going to zoom in this. Consider prescribing 150 mg of aspirin at night, less than 16 weeks as appropriate. And also, you have to do uterine artery Doppler. Now, when do you do the uterine artery Doppler is given here. In high-risk population, uterine artery Doppler at 20 to 24 plus 6 weeks of pregnancy has a moderate predictive value for early onset SGA. In women with an abnormal uterine artery Doppler at 20 to 24 weeks of pregnancy, subsequent normalization of flow velocity indices is still associated with an increased risk. So what they have said is that you can do at the routine anomaly scan, right? So that's why I had selected the answer as 18 to 20. Okay. Now again, there can be a controversy in this because a 20 to 24 can also be a correct answer here. So I'm gonna stick to O instead of N because they have in the guideline given it as 20 to 24. Okay. Please look at this. Okay. So the correct answer here is O. And the next, so this is something that I want you all to please learn because this table is slightly different from the previous one. So I want you all to learn this and not the older SGA table. This is what is important. And for amniocentesis, this karyotyping should be offered in severely SGA fetuses with structural abnormalities and in those detected before 23 weeks of gestation, especially if uterine artery Doppler is normal. In this patient, the presence of polyhydramnios and a symmetrically small baby suggests that the problem is unlikely to be placental, hence a uterine artery Doppler would not be beneficial. So, first of all, polyhydramnios and IUGR don't go hand in hand, right? So that is when we have to think that what are the most common cause of symmetrical IUGR is, to be honest, chromosomal abnormality. So that is something that we want to see, and for that we would need amniocentesis. Okay, are you all clear, guys? I want you all to please answer. Please look at this algorithm. Okay, please go to the guideline, go to the last pages and screenshot this from the guideline. Okay, this is updated. I'm thinking there will be a question from this. Okay, next question, 28 to 30. Guys, y'all want me to zoom in for y'all? Don't read the options first. Train your mind to go to the question, form an answer, and then go back to the options. So what are they saying here? When would we stop? These are your options. Okay. Dr. D is saying D, and Dr. Husni is also saying D. Ruby is also saying D. This is something that we do every day, like in our clinical practice also. If first patient is on LMWH, we withhold it after, withhold it for 24 hours before her either induction or cesarean. Okay, great, you're right. Next question. So, Dr. Ruby, there is a difference in the dose of maintenance and LMW and therapeutic doses. There is a table given. Please go to the GTG, or if you want, I'll share it. The doses are different. Therapeutic dose is different and maintenance dose is different. Maintenance is prophylactic. Therapeutic would be given for someone who has a thrombosis, right? In terms of stopping, yes, 24 hours. 24 hours. Sorry, I got your question wrong, but yeah, stop. We stop 24 hours before because it's related to the half-life of LMWH. For heparin, unfractionated heparin, we usually stop 6 to 12 hours before because its half-life is lesser. LMWH has a longer half-life. Okay, so nobody's answering the next question. 24-year-old who had a DVT at 29 weeks. Dr. Manikam says J. Clincher for you guys is epidural catheter. Dr. Pradeep says H. Hint, guys, is it 4 hours or is it 6 hours? You all are correct. Dr. Ruby again hint. Is it 4 hours or 6 hours? It's 4. Yeah, no, it's 4 hours, Dr. D. I'm sorry, I do not know your name, so I'm just calling you Dr. D. It's 4 hours. So the correct answer here is H. Okay. It's 4 hours for the epidural catheter. You go back to the guideline. We'll look at it. We'll look at it in the answers. It's 4 hours after removal of the epidural catheter. Next question. Look, I'll give you all the questions again. So the hint here I'm giving you all is each option may be chosen once, more than once, or not at all. Sorry. Yeah. I'm going to zoom it out because you all will not be able to see the options otherwise. And I've given you all a major hint now. Yes. Okay. Dr. Ruby says D. Dr. Husni says C. Why 12 hours? We just had this discussion, dear. Dr. Chaiti, hello. Yes, she says as D. Dr. Pradeep says D. Okay, correct. You all are right. It's D. So this is the option that it can be chosen more than once. So even when you're examining, you're thinking, okay, you're 100% sure, but the answer is repeating. So don't just change the answer because you're thinking it's being repeated, okay? Because that's mind, and especially mind in your exam would come up with such crazy stuff saying that, oh my God, it's repeated. Is it right or not? Okay. But if you're 110% sure that this is in the guideline, doesn't matter if the answer is being repeated. So you all were correct. I'm glad you all could answer this correctly. Um, This is D. This is also D. And this is which is the 4R option. It's H. Okay. So this is your answers. Discontinue LMWs 24 hours prior to the delivery. LMW should not be given for 4 hours after the use of spinal anesthesia or after an epidural anesthesia. So you have to remember the time here is 4 hours, not 6 hours. And discontinue LMWs, again the same answer, 24 hours. Okay. Moving on to the next question. Oh, this is malaria now. Again, I like this guideline. It's good. So these are the questions. So I'm gonna, once you all have read the first question, I will change on to the answer because it was not fitting in one slide. Okay. So just please type in change so that I can change the slide once I'll read the first question. Don't concentrate on the questions below. Okay. So just tell me when I should change. Shall I change, guys? I'm changing the slide. I think you all have yes, thank you, Dr. D. Now these are your options, and you all are gonna get boggled by these options, so your answer has to be ready in your mind. Dr. Husni says B. Waiting for more answers. Dr. Chetty says B. Okay. I'm waiting for a couple of moments, like a minute more, and then I will have the discussion. Like, let's just answer all of it together and then discuss it together. Okay. So most of you are answering B, and that's the correct answer. Now let's look at the next question. So now when I give you the guideline, you will be sure, Dr. Ruby. For every patient of malaria, you have to admit. Okay, that's given in the guideline. Whether it's not, it's just complicated or uncomplicated. Complicated gets admitted to different care, right? Level of care, and uncomplicated would be in the ward. So yeah, its admission is compulsory. 30-year-old woman, 28 weeks pregnant, presents abroad with symptoms like vomiting and flu, but has no pyrexia. She has been diagnosed with P-Vivax malaria by the acute medical team. So here it was falciparum, and here it is Vivax. So your drug would change. It's okay, it's easy. So here now you have to search. So once we know that we have to admit, so these options are out. Allow home, postpone any treatment. This is all out. Okay. So now we can, another way of outing this is, we know that it's not severe or complicated malaria, right? It's Vivax, simple Vivax malaria. Okay. I'm sorry, you all are correct. This is F. Next, please. Again, this is easy because in your options, it was an easy option. Correct, Dr. D. So here, in all your options, there's only one ICU. Correct. But don't forget to look at the dose for your revision. We give artesunate and complicated malaria. Okay, I'm happy all were able to do this well. So the correct answer for this, the first one was uncomplicated falciparum. You admit to hospital, administer oral chloroquine 600 mg. Wait, which one's this? Yeah, sorry. Admit to hospital, give oral quinine and oral clindamycin. It is advisable to hospitalize all pregnant women with malaria, especially P. falciparum, as women can deteriorate rapidly. Dr. Ruby, for you, women should be managed jointly by the medical and obstetric teams. Okay. If vomiting is persistent, you can go to IV. Primaquine not used in pregnancy. I'm really sorry. I'm going to erase all of this out. Erase all in con slide. Yes. Okay. Next is F. Chloroquine is to be given for Vivax. Then next is admit in ICU IV 2.4012 hours. And also MDT. Very, very important. Easy questions now. Sorry, what was 31 answer again? I will go back, doctor. 31 was B, oral quinine. If you go to the table in the malaria treatment GTG, you will find the table will have the first option as this. Okay, giving you all 2 minutes, guys. I just need to grab a sip of water, so I'm gonna give you 2 minutes. If you're comfortable, you all can answer all the 3 questions together as well, because the options are just given up and it's the easier questions, okay? A 27-year-old priming gravida is being followed up with regular ultrasound scans as a part of monitoring of MCD at twins. She is now at 26 weeks. There's a discordance of 25% with a positive velocity in both umbilical artery assessments. So this is FGR. Correct answer is A. E. H. All right. Okay. Very well done, guys. I'm just giving all this table from the guideline. AEH. Correct. Okay, moving on. This is something that is it's just factual, so I'm not going to much details. But twins is an important concept, so I wanted you all to know. Twins, we have the nice guideline that you all should know. Okay. There's, I think this is taken from the GTG. Okay. This table. Next question. is the GTG number 51. Okay. Dr. Hosni and Dr. Ruby both say A. Dr. Chetty, good. N. Dr. Ruby, why would we give someone desmopressin again if she's not responding? Right, dear? We wouldn't give it because it's already not responding. And as a matter of fact, it has gone down. It has just increased it 0.35 to 0.4. Right? We want her values to be at least 0.5, right? So here the answer is you give factor 8. So the correct answer is N. Next question, guys. Okay, Dr. Manikam, Dr. Husni, Dr. Ruby says A-O, Dr. Prateep says NA. I think you're answering both the questions. The N is correct, the A, however, is not. Because here the correct answer is O. As you see, doctor, she's going for evacuation of retained products of conception and her value is 0.4. Okay. And so before a procedure, invasive procedure, we have to have values which are higher, right? So here we will have to give her factor 7, right? Hemophilia B is factor 9. So this will be O, recombinant factor 9. Okay. Desmopressin so the first answer is N. Desmopressin can be used antenatally to raise factor 8 levels due to its antidiuretic effect. Fluid restriction has to be done to 1 liter for 24 hours. Important point. Recombinant factor 8 should be used if levels obtained are insufficient or in the known non-responder. Okay. Then next is factor O, recombinant intravenously. Factor 9 intravenously. Recombinant factor 9 is required to cover invasive or surgical procedures in women with factor 9 deficiency, whose values are less than 0.5. These factors are administered intravenously and clotting factor should be checked prior to administration and 4 hours after facilitating after to facilitate dosing. Right? This is also important point. Next question. Again, easy questions. You all will be able to answer this well. Before we are at, I think, question 3940, there are 51 questions in obstetrics. We will take a quick 5-minute break after that before we begin the gynecology session. Dr. Ruby, Dr. Manikam is saying L. Dr. Pradeep is saying E. Dr. Sam is saying D. No, Dr. She has to stop taking that drug. Dr. Eman and Dr. Pradeep, I'll give you a hint that if you go further down the option list, you'll get a better answer. Okay, so you all are right. The answer here is L. Yes, Dr. Eman and Dr. Pradeep. I just wanted to tell you all that when we stop hydroxycarbamide, for it to get washed out, it at least needs 3 months. And that is why we tell the patient that we tell her that you stop the hydroxycarbamide and you take contraception for 3 months. Now, if this option was not there in this list, then you would have chosen E. Okay. But when this is given, because this is more correct, right? Because we don't want her to get pregnant in those 3 months. This is the best answer. This is the second best answer. However, if this was absent from the option list, then this would have been obviously correct. Another thing that I want you all to want you all to understand is that some people might get confused with J because that's angiotensin converting enzyme. Angiotensin converting enzyme is also to be stopped, but there is no time limit for which they have given. They can say that they've just said that stop before pregnancy, or if she gets pregnant and she's on this antihypertensive, you have to change it, right? So that is why don't choose this answer. The correct is hydroxycarbamide. Please answer the next question. Mm, okay, Dr. Ruby says B. Easy. This one's an easy question. I'm glad you're answering it well. Yes. Dr. Iman, Dr. Manikam, Dr. Husni, Dr. Ruby have answered B. Okay, so you all are right. Dr. Pradeep, you are right as well. The correct answer is B. Okay, you have to give influenza virus vaccine and it is given yearly. If you all remember, I had it's some are 5 yearly and some are yearly. If you remember from the session that I had taken, it's clearly given in the guideline which is to be given at what interval. So influenza is to be given at 1 yearly interval. Now next is question 41. Dr. Manikam, Dr. Husni have answered I. Okay, Dr. Manikam, Dr. Husni and Dr. Ruby are all saying I. Waiting for a couple more answers. Okay, so you all are clearly correct. The guideline, if she has anemia, the first thing you have to do is to see her iron levels. Yes, Dr. Pradeep, you're right. This is correct. Answer 9. Influenza vaccine is also correct. And this is important. Undertake a further test. You have to assess the iron levels before giving any form of iron supplementation. Okay, this is the placenta previa guideline. Clincher for you here is Jehovah's Witness. B/G. C. Correct. Dr. Ruby and Dr. Chetty, you all are absolutely correct. Dr. Iman also, you are very correct. So all of this is right. Okay. But you first have to refer her to a unit which has cell salvage and or interventional radiology because this is Akreta spectrum that we're talking about. Okay. So it is right that you need hysterectomy. But she's a Jehovah's Witness doctor and not all centers have cell salvage. Now, if your center had cell salvage, you might proceed with it, but you would still do maybe embolization before that. So this is the best answer. And you're right, Dr. Manikam had answered autologous blood transfusion. But if you do not have the facility, then what? So even in the guideline, they've said that first refer to whichever center has this patient, these facilities because it's not everywhere, right? Cell salvage is not going to be available everywhere. This is 43rd question is easy. You all will be able to do it well. Okay, I understand why Dr. Hushni is answering A. Because in the algorithm that they have given, they have said that you can do a TVS when we would prefer doing a TVS if she's obese, if she has posterior placenta. Okay, Dr. Manikam, correct answer is J here. If you all remember the algorithm in the green thing that we have, in the first box, they have written bracket TVS and they have written posterior placenta and obesity, if I'm not wrong. I don't have the screenshot, just give me a minute. Okay. So consider TVF is posterior placenta and or high BMI. So here there's nothing, right? In our, if they had said a para 2 with previous normal delivery is has a BMI of 40, she has found to have a low lying placenta on an abdominal scan on her, which was done during her anomaly scan. What would you suggest? Then maybe we can answer transvaginal. Okay. Then you can answer transvaginal, but now this points more towards a repeat TAS or TBS at 32 weeks. Can you all visualize this? If you all want, I will, I don't know if I can share it here right now. I unfortunately don't have a screenshot of that. I will send it on the group. So refer to answer C. With the previous cesarean section and ultrasound features of a typical, or which are typical of placenta accreta, this woman is a high risk of postpartum hemorrhage, as she is a Jehovah's Witness and most likely refuses blood transfusion. She would require a discussion with the patient and the completion of advanced directive. The woman would be referred to a unit with cell salvage and or interventional radiology so that a planned elective cesarean section can be performed at 38 weeks with these extra modalities to reduce blood loss at surgery. Okay, and this is done. This was correct, so I'm not going much detail. Okay, Dr. Manikam, I'll ask the backend team to do it. Okay, so you all have answered C. I want you all to understand one thing, guys, that this is a scientific impact paper number 1, air travel in pregnancy, extremely high yield. It's a short read, hardly 4 or 5 pages. I want you all to read it throughout because you please, this is important, okay? It's an old paper, but an important paper. So C is correct. Please answer the next one. Dr. Ruby says E. Dr. D is right. So twins, you have to avoid flight after 36 weeks because there is increased risk of preterm labor, right? So when there's increased risk of preterm labor, you avoid it after 32 weeks. I'll show you all in the explanation, guys. Uh, J. Dr. Husni says J.
Dr. Ruby, what is 26 weeks given? Okay, so we'll have a discussion on this. Dr. Ruby. Dr. Manikam, Dr. Pradeep is answering J. Dr. Ayman is answering A. No, that's not right, unfortunately, Dr. Ayman, because this is an absolute contraindication for traveling. Okay, why? Can you all tell me why?
Anemia. Hemoglobin less than is 7 grams.
Yes, very good, doctor. Thank you for telling me this. If it is less than 7, it's an absolute contraindication. Okay, so this is J. So this was right. Whilst the graduated elastic compression stockings is correct. The main risk with air travel in pregnancy is the risk of labor and facilities not being available to provide care for women in labor. Therefore, women with additional risk factors for preterm birth, like multiple pregnancy, are generally advised not to travel after 32 weeks. So here they are saying that she can travel at 26 weeks, but she can't travel after 32 weeks. Why would you give her if she wants to travel? Yes. So if she wants to travel at 26 weeks, she can travel. Is there an option in this? You can't select no additional risk, okay? You can't select no additional risk because she has a high risk of preterm labor. So that becomes obviously an additional risk to travel. Then next is low dose aspirin doesn't fit graduated elastic stockings. mm, You know, not again because it's not gonna fit here. LMWH for the day of travel. If you want, I'm gonna at the end of this session, I'll open up the paper on air travel and we'll just quickly discuss it. Okay. I know it's a little late in India, but give me a couple of more give me a hour at least. We'll be able to finish the gynac. Okay, this is the paper, Air Travel and Pregnancy, Scientific Impact Paper 1. Severe anemia less than 7.5, recent hemorrhage, otitis media or sinusitis, serious cardiac or respiratory disease, recent sickling crisis, recent GI surgery, a fracture with significant less leg swelling. All of this is contraindicated, okay? We will have a discussion on this. Please, if I forget, please remind me. Again, easy questions. I know we'll be able to answer this properly. Amazing, all of you are right. It's amniotic fluid embolism. Okay, it's a textbook description of amniotic fluid embolism. So that is A. Next question, guys. Here you all have a clincher. Left tracheal deviation is the clincher. Dr. Ruby is saying M. Dr. Eman, Dr. Husni is saying M. Any more? Dr. D is also saying M. Amazing, guys. You're right. It's M. It's tension pneumothorax. These are classical. This is all from medicine, what we've learned in MBBS days. It's A and M. You're right. Okay, next question. Uh, okay, this is preconceptional care of diabetes. Can you all see it clearly or you all want me to zoom? I think you all can see it since no one is telling me to zoom in.
Okay. "35-year-old diabetic woman has been seeing in the preconception clinic for counseling. Her HbA1c is 9.5. She's referred with retinal and renal assessment, and they're normal. Her BMI is 30. You tell her she needs to lose weight. What form of assessment should be offered before she leaves the clinic, assuming that she's not ready for pregnancy? She's currently self-monitoring her blood glucose by taking fasting and postprandial samples." Yes, doctor, all of you are correct. It's we. So comments on folic acid is right. That's going to be correct, Dr. Husni. But what is important is that we need to do monthly HbA1c till it's normal for preconception, and you have to give her a contraception as well that she doesn't get pregnant, because 9.5 is very high. There's increased risk of malformations in them. Okay, so this is B. Next question, guys. We're at the end of the obstetrics part. We'll be discussing gynec after this. Okay, Dr. Ruby is saying D. Dr. Hosni is saying D. Dr. Pradeep is as well saying the same thing. D. Yes, you're right. Advice against pregnancy. Why X, Dr. Manikam? What is X? Optimize glucose control. Yes, that is there. But at 10, the first advice is we do not get pregnant and give a contraception. They have not given contraception anywhere. So, yeah, it's D. Advice against pregnancy.
Ma'am, she's on COCP, ma'am.
Uh, she is already on. So, yeah, you need to advise against COCP. So, just advice against pregnancy. She's come to you in preconceptional counseling. Agreed, we have to do the optimization of her glucose. But so to be honest, that would not be our problem, right? We would have to refer her to an endocrinologist for that. Okay. So if the best answer would be to refer to an endocrinologist, which is again not in the options, if I'm correct. Yeah, it's not in the options. So here the best answer would be advice against pregnancy. Best would be refer to endocrinologist, but it's not in the option. So again, advice against pregnancy. I understood your point that she's already on OC pills. Are you all answering the next question, guys? 47. Correct. Why? Because her albumin creatinine ratio is more. It's M. You have to refer to nephrologist. Okay, I think you all are clear about this. This was the preconceptional counseling um, for diabetes. Another important thing in diabetes is to know the values. What are what are our goal values? What is high? What is low? It is also for us. It is very important to learn because we are not familiar with their units. We do in deciliter, or we do in gram per liter, but they do it in millimoles, right? So we need to learn that specifically. Another thing is the DKA. The DKA part is important, and the preconceptional counseling is important in the diabetes guideline. So now we will be starting with the gynecology guideline. Just it's again another 51 questions. So let's begin. I have given the option list first. Now again, these are a little controversial questions, but I wanted to include questions on this. So shall I show you all the questions and then come back to the slide? Just tell me when to go back. Once you read the first question, tell me go back. I'll go back to that slide. Guys, can I give you a hint? She has occasional stress incontinence. However, on neurodynamic studies, she has no stress incontinence, but she has detrusor contractions after standing up with full bladder. What does that mean? She has urge, right? Overactive bladder. And if she has overactive bladder, if you do the prolapse surgery, will it worsen it or improve it? Okay. So what the answer that they've given, this is taken, I think this is taken from Andrew Sizer. I think I don't remember the book that I took this from. It's it says that you have to defer surgery until bladder stable because her main problem right now. So she is not coming to you with a complaint of overactive bladder, right? She's not coming to you with urgent continence. You have gotten it on urodynamic studies. Let's look at the question again. There is sensory urgency. So it's telling you it's having, there will be contraction, but then it will be during voiding, right? And it's phasic detrusor contractions during the, when the bladder is full. So no, this is, I understood your question, but they have given you the hint here, sensory urgency. So now she has irritative symptoms, occasional stress incontinence that has been ruled out because there is there is a urodynamic urge incontinence, and her reason for referral is bothersome prolapse. So our aim is to correct her prolapse, right? But we all know that we cannot do a prolapse surgery when she has urge incontinence because it's going to obviously worsen her urge incontinence. It's not going to help her urge at all. So if we want to treat her prolapse, the best answer here would be to deal with the bladder before we do the surgery, right? Before we do the prolapse, we have to get the bladder. Um, what do you say? We have to get it in control. This was a difficult question because it was confusing for me as well. But when I thought about it, I understood why they're saying is that because if imagine this patient came to you in your practice, doctors, you would also definitely deal with the bladder first before posting her for a surgery. Okay. This is one thing where I actually reverse went back to my what we do in our practice clinically. So let's look at the next question, guys. So here, definite detrusor overactivity observed. That's the clincher for you guys. You all are correct. The answer is A. This is right. Next question. Simple. I'm not gonna discuss much. This is a difficult question. Oh, sorry. I'll go back to the options.
Okay, you all are correct. The answer, however, given here is MDT. Okay. This says that the resident should be referral to MDT, but I would agree with you all because whenever there's hematuria, there has to be a reference to urologist because it could be a sign of carcinoma as well. Okay. So I agree with you guys. This is the answer that they have given. I'll show it to you all after you answer all of these questions, or you all will be able to look at the other answers as well. Let's look at the next question, question number 4. Okay, what do you guys think is the correct answer? Again, I'm not very comfortable with this question because so this answer, doctors, they have actually given H, which I don't, not H, sorry. Uh, it says G, which I'm not sure what they mean by that, but that is the answer given. We will have a discussion once you just answer the last question and we'll talk about all of them together. Question. I was like, which is Q option? Yeah, sorry. Okay, options. I'm so sorry. I know this is a little difficult, but the question and the options are too big to fit on the same slide, guys. I'm really sorry. Everybody has different answers. The correct answer here, however, guys, is multidisciplinary team.
management. So let's go step by step. Let's answer all of this. This was a difficult question. I'm sorry I put this as the first question, but don't worry. So this point I think you'll have understood. This you'll have understood. Now this, first of all, in this situation, blood staining post residual may highlight something sinister. So I don't think so. This is the correct answer. I would go with K here, which is refer to urologist. Okay. Next is counseling regarding after effects of the surgery. So the explanation that they've given is that after contractions of the bladder observed during voiding cystometry may worsen following surgery and be indicative of a de novo detus or overactivity. Therefore, this needs to be discussed prior to surgery. This again doesn't make sense because she's already had surgery. Okay, she has a total abdominal hysterectomy 3 years ago, and lower urinary tract symptoms have developed ever since. Right, so what more surgery they want to do, I have no idea. So this again, I would go with an MDT. So this answer would be, what was the MDT? It's E. I would go with E for this. And for fifth, they have said again E, because there is evidence here of detrusor overactivity even on maximum dosage of anticholinergics. The next step is to start botulinum toxin, but they say that before starting botulinum toxin, you should do a MDT. Okay, I hope this has answered your questions, guys. Next question. This is on. Do you all want me to zoom in, or can you all see properly? Before Botox, we do MDT. Correct, Dr. Hassan? Okay, most of you are answering I, and that is correct. Because in the guideline, it says the CA, you have to measure CA 19.9. In reality, we would actually be doing all of the markers, but the guideline says that you do only CA 125. Okay, next question, guys. Okay, so the correct answer, unfortunately, here is, guys, you have to do a complete examination, a complete clinical examination, and the correct answer here would be a full physical examination, which is F. Okay, so if you open the guideline, the green top guideline number 34, it's on the first page. I'm not sure if I can I share photos here? So I've asked the backend team to share a photo of this so y'all can go through it. If the patient has IBS, she needs a full examination with including PMI abdominal examination to detect ascites and characterize if any palpable mass is there, and a vaginal examination as is there on it. It's been amended in 2016. Okay. I will see if the backend team can share the picture. Next question, guys. Okay. You're right. It's B. Because when we think that it's if RMI is more, then you have to do a scan, CT scan, and refer to oncology. Okay. So the correct answer is for number 8 is actually I. Okay. Because what individualized treatment or discharge from follow up? Yes. So what they have said is in the guideline is basically that would asymptomatic cysts which remain unchanged, what would you do for them? So in this that they have clearly stated asymptomatic simple unilateral unilocular ovarian cysts less than 5 centimeter have a low risk of malignancy in the presence of a normal CA125, and the cysts can be managed conservatively. However, we do not have a CA125 in hand, guys. Right? Do we? We don't. So we have to do a CA125. And depending on the CA125, if it is normal, then you can do conservative management, or it depends upon the patient's wish also. If she wants to go in for a surgery, it's her wish, but we can also do follow up and reassure and do conservative management for this. Is this clear, guys? So you all were right. You all have to do about because it's unchanged. But one important factor which is left out was that we do not have CA125 level in our hand. So that is why they have said we need to do CA125 here. Are you all understanding, dear? Please tell me if you're having confusion. Let me know. I don't know if the backend team can update the photo. I'll put it in the group after the session. Okay. So it is recommended that ovarian cysts in perimenopausal, postmenopausal women should initially be assessed by measuring serum CA125. So this is the only thing that they've given, and this
the guidelines clearly states that if it's remaining unchanged, we can go for conservative, but only and only if it's CA 125 is normal. Next, guys, this is menopause. Again, important guideline. The nice guideline on menopause. This is the right answer, Dr. Hassan, but only after when we know the CA 125. Okay, you're right. E is the correct option because she has POI. In POI, we need to replace with HRT, and she's already having amenorrhea, so you give combined. You don't have any other option only. So this is the correct answer here, E. Dr. Manikam, there is no role of CBT in POI. I wouldn't say no role, but we have to give E plus B for this patient because she is having symptoms like hot flashes, night sweats, and loss of libido. And even for her bone, to be honest, because POI will have osteoporosis. Question number, so this is actually question number 11. Yeah, 17. Well, correct. This is CBT because she is having low mood and she's otherwise well. That is why we are just giving her CBT. Your clincher here is total abdominal hysterectomy. Dr. Dr. Husni, please. Yes, thank you. That's fine. F is, you're right, guys. Dr. Manikam, Dr. Pradeep. F is right because it is hysterectomized, right? We do not need to give progesterone coverage for her, so we just give estrogen. 56-year-old woman, next question. You're right, it's correct. We have to give testosterone when even on E plus P, her libido is not coming back. You give you give testosterone. Last question, clincher, breast cancer with tamoxifen use. Okay. Dr. Ruby, Dr. Pradeep, Dr. Sabha. You all are saying O and you all are absolutely right. We have to give vaginal estrogen. You all are good with this. This is only thing for the breast cancer that I want you all to see. First of all, you can work with a breast cancer specialist. So if this was option, you can use this also. Otherwise, we can give vaginal estrogen may be used in combination with a non-hormonal moisturizer or a lubricant. Consider women. So first line, you will give lubricant. Do we have a lubricant in the option? We don't have lubricant in the option. This is taken from the screenshot. This is taken from the current guideline, guys. They say that you offer non-hormonal moisturizers or lubricants to people with personal history of breast cancer and genitourinary symptoms associated with menopause. Consider vaginal estrogen for people with personal history of breast cancer and
genitourinary symptoms that have continued despite trying non-hormonal treatments. Okay. Vaginal estrogen may be used in combination with a non-hormonal moisturizer or a lubricant. However, they also say that you have to involve the breast cancer specialist. I agree that it is a risk, but since vaginal estrogen has a lesser systemic absorption, there is an absorption, but you can still give if the lubricants have failed. So the ideal answer here would have been lubricants, but it is not given in the clonidine is definitely not an answer, Dr. Hassan. No. Next question, guys. This is for ectopic. I'm really happy that all of you are actively answering and learning. And despite that, we are almost 3 hours into a session now. We'll be reaching 3 hours and half an hour. I'm hoping I'll be able to complete in 45 minutes. Be glad you're hanging in and answering. Okay, no one's answering. Are you all awake? Dr. Hassan, no, Dr. Ruby says K. Clincher for you guys here is salpingotomy. So that is easy. How do you monitor salpingotomy? You are correct. Very well done, guys. Salpingotomy, you have to repeat beta HCG almost. What do we say? On day 4 and day 7. And another thing is that 1 in 5 women would require either maybe a further treatment for it, for the the maybe a salpingectomy or a further major treatment. Okay, next question. Beta HCG on days. You're right. It is I. We do baseline beta HCG, which is already done, and then we do day 4, day 7, and then we do it weekly till it is less than 15. Dr. Manikam, we do it weekly till we get a negative answer. Are you all answering the next question? So, next question. So Dr. Husni is correct here. So what is happening is that they have said that you repeat a TVS before giving the further dose, because what if it's going towards a rupture? What if it's increased in size? What if it's not, what they're saying is that you have to do a TVS, you have to do a whole complete reevaluation of the patient and see whether the patient is still fitting into the characteristic of medical management or she would need a surgical intervention. Okay. I understand that. Confused between P and Q. I will clear that confusion right now. See, following methotrexate treatment, serum beta HCG level should be measured on day 4 and 7 and then weekly unless less than 15 international unit per liter. Dr. Manikam, kindly note this. If levels do not decrease by 15%, a repeat TVS should be performed to exclude ectopic cardiac activity and the presence of significant hemoperiton. Okay. I don't think so you all can see this clearly, so I'm going to show you all the first questions first. So the patient is a 23-year-old woman who is on the combined hormonal oral contraceptive pill and just missed one pill. I think all of you all know the correct answer to just missed one pill. I'm going to zoom this in for you all. It's N. Correct. Okay, so what I'm going to zoom in for this also. So I don't know what they have done here. They have given N, take an active pill as soon as remembered and resume normal pill taking. No need for additional precaution. And they have actually marked U as the answer, which says that take the next active pill as soon as remembered and resume normal pill taking. No need for additional precautions. They have actually marked U here instead of just saying take an active pill as soon as remembered. It is saying take the next active pill as soon as remembered. Okay. Wow, this is a really difficult one. Even I would have gone wrong with this. Okay, so this is with regard to patch now. Again, contraception is something that there's a 110% question on. So must read and must revise. So this patch has fallen off for less than. Okay, so I'm gonna ask you all one thing here. So let's look at options first, which have patch. Okay. So take an active pill, take an active pill. This is not there. Okay, start new patch as soon as remembered, giving a new day one. No, we're not doing this. Reapply patch if sticky to the same side or replace with a new patch, giving it a new day one of the patch cycle. No need for any contraception. Okay, let's look at other ones. Do we have any patch? Apply new patch immediately and next patch change day remains. No additional precaution required. Okay. Okay, so they are answering it as reapply patch is sticky to the same site or replace with a new patch and change patch on the usual day. No need to use any contraception. So again, the clincher here is 24 hours because if it is more than 48 hours, just replace, no additional. Correct, Dr. Hassan. And also you do not need to change the day. It remains the usual date of changing. Okay, so F. Yes, Dr. Ruby. I'm sorry, I think you all went wrong with the options because the options were given in a bad way. If you all would have read this in continuity, you all would have marked F because we change the day. We give a new day only when it has crossed 48 hours. Guys, please note all of you all, Dr. Pradeep, Dr. Husni, Dr. Ruby, please note this, okay? That 24 hours is given. And if you all remember about the patch, the CHC uh, incorrect usage, it was patched more than 48 hours. Okay. Has been dislodged for 36 to 48 hours. So here it is 48 hours. Now what would you do? So now the first thing that we know is that the patch has fallen for 48 hours, right? 36 to 48 hours. Emergency contraception plus new patch plus additional contraception for 7 days. Okay, correct. It was the patch, not the pill, dear. So stop current patch cycle and start new 4-week cycle immediately by applying a new patch, giving a new day additional precaution. Wait, let's look at the question again. Someone's mic is on, please. Please mute yourselves. The woman is 28-year-old teacher who noticed that a combined hormonal contraceptive patch has been dislodged for 36 to 48 hours. If a patch remains detached for more than 24 hours or if the user is not aware when the patch became detached, then stop the current contraceptive cycle and start a new cycle if applying a new patch is given a new day one. An additional non-hormonal contraceptive must be used for the first 7 days of the new cycle. Okay. Now this is something I will need to review because if I'm unable to recollect. Again, this will be put on the group, guys. This will be put on the group. I have to put up a couple of stuff. I hope I remember it. What I remember is air travel, scientific impact paper, the one guideline before this and this now. Okay. Last question. Now here, since she's had an unprotected sexual intercourse, we would be giving the emergency contraceptive, right? In the first one, they did not say emergency contraceptive because there was no unprotected sexual intercourse. Okay. So this is start new patch. Where's the patch options? Okay. Start new patch as soon as remembered, giving day one additional hormonal non-contraception needed for the first 7 days, an emergency contraception if intercourse has occurred. Okay. So it has occurred. So that is why that is the correct answer. So I will be putting up this on the group as well. Okay, you all are saying C. This was 3 years ago and a snowstorm appearance. This is very classic. You all cannot go wrong in this. You are correct. Next question, guys. Okay, choriocarcinoma is correct because it's edematous trophoblastic villi and no obvious chorionic villi. Correct. Next question. You guys are amazing. It's right. It's D because you can see that the value has plateaued at 10,000. Okay. So this points towards GTN. And how would she be managed? She would be managed by an MDT, and depending upon her WHO stratification, she would be started on the treatment. Next question. Oh, this is again, my options are on one page and my questions are on another. I'll show you all the questions first. I'll read it with you also, it's easier. A 27-year-old presents with sudden onset painful ulcers on the vulva. One important point, painful ulcers. And around the anus. These started as swellings that quickly ulcerated. There is associated swelling and pain of the groin with no associated vaginal discharge. This was soon followed by swelling in the groin. On examination, there are multiple anogenital ulcers with clinical features of lymphadenitis. So clincher is two, painful ulcers and lymphadenitis. What is this? Painful ulcer and is the lymphadenopathy painful? It's chancroid. Okay, Dr. Hassan says chancroid. Dr. Husni also says chancroid, caused by Haemophilus ducrei. You guys are right. It's F, chancroid. Painful ulcers with lymphadenopathy. 20-year-old woman presents with multiple ulcers on day 4 of 4 days duration on the vulva. These ulcers followed rupture of painful blisters. Her last menstrual period was 9 days ago and she is on the combined oral contraceptive pill for contraception. On examination, the vulva is inflamed and contains superficial tiny ulcers with an erythematous halo and yellow base. There is bilateral inguinal lymphadenopathy. The clincher here is superficial ulcers with erythematous halo and yellow base, and it's painful. Correct. Herpes is correct. HSV. You guys are amazing. You're doing well. Yeah. So HSV is right. This is option. Where is HSV? It's J. Next question. A 26-year-old presents with widespread rash of 3 weeks duration. There is associated fever, headache, and occasional bone pain. On further questioning, she revealed that she had noticed a similar rash on her vulva a few months back. But these rashes resolved without any treatment. Examination shows widespread maculopapular rash on face, hands, and soles. No, Dr. Hosni, look at it again. What syphilis? Primary, secondary, tertiary? Be specific. Don't answer S, guys. Be specific. Secondary. Very good. It's secondary syphilis. Classic clincher. Rash on the maculopapular rash on the palms and soles. Classically seen in secondary syphilis. Amazing, guys. You are doing really well. So this is R. Last option now. The last question. A 40-year-old woman complains of ulcers on her vulva of 1 month duration. They are not itchy. and there is no vaginal discharge. On examination, multiple whitish flat top nodules are observed on the vulva. The nodules are thickened but not ulcerated. Flat topped purple nodules are located on the wrist clincher. Lichen planus. Correct, guys. Amazing. Why lichen planus? Because lesions of lichen planus may be seen on the mucous membranes on cutaneous surfaces, such as the inner surfaces of the wrists and lower legs. These cutaneous lesions are usually red or purple flat top nodules or papules with an overlaid white lacy pattern. Involvement of the vulva is usually with white patterned areas that are sometimes elevated and thickened and may appear red and raw. 4 is there are 4 P's. Dr. Hassan, you can share with us if you want to. But I'm really, really happy that you all were able to answer this very well. Okay. Now moving on to the next question. Okay, so first is a 32 woman PCOS. You all are answering. I'm sorry, I can't see this. Okay. Sorry, I don't have answers. I've by mistakenly not gotten the answers, but here the correct answer is cyclical progesterone. D for withdrawal. Okay. A 48-year-old woman with a PCOS is investigated for amenorrhea of 9 months duration by means of a transvaginal ultrasound scan. Her endometrium is reported to be 8 millimeter thick with no other abnormal findings. What would you do for this? Her this is thick, right? It's 8 millimeter. What is the cutoff for PCOS? 7 millimeters. Yes. So you would do an endometrial biopsy. Very good, guys. You're right. Endometrial biopsy. Next question. A 43-year-old woman who presented with amenorrhea of 12 months had an ultrasound scan that revealed an endometrial thickness of 9 millimeters. She had an endometrial biopsy with a pipille, and this has been reported as hyperplasia with ertypia. What would you do? TE, hysterectomy with BSO. Correct. Dr. Husni will also remove the ovaries. We remove the ovaries. So the correct answer is T here, total abdominal hysterectomy with bilateral salping oophorectomy. For hyperplasia with ertypia, we remove all, basically. Yes, correct, Dr. Manikam. Dr. Pradeep, please note that we also remove the ovaries. Okay. I unfortunately do not have the answers because I think I've done some mistake in making the slides here. So here the correct answer is T. So I'm just going to mark it down for you. D, F, and T. Okay. So this is again contraceptives for you. Clincher for you guys is that she's been on the hormonal pill only for 2 months. So please look at that as well. It's not 3 months, it's 2 months, right? You're all correct in saying that we have to increase the dose of you have to change the pill, but that is done only after 3 months, not 2 months. Okay, so 2 months is reassurance. The correct answer for the 26 number is P. It's not 26, actually, it's 31. But yeah. You reassure and ask her to follow up, guys. You cannot just leave her at reassurance. You have to reassure and ask her to follow up. You have a better answer here. They have given you how classically the EMQs confuse you. Yes, we will reassure. We all know that we have reassurance, but she will be asked to follow up after a month, right? This is classic how they confuse you. Next question. A 25-year-old was placed on the combined contraceptive patch by her GP 3 months ago. She has never had a cervical smear and presents complaining of unscheduled bleeding. She has been in the same relation for the past 5 years and has no suspicion that her partner has been unfaithful. Okay, Dr. Husni and Dr. Ruby are saying R. Right, this is R. We have to get examination done. And obviously smears because she is not done, not had smears. Last question, question number 33. 27-year-old woman started on 30 micrograms of ethinyl estradiol, presents with unscheduled bleeding for the past 4 months. She has had a cervical smear 2 years ago, which is normal, and has the GP who has referred to you has excluded pregnancy and improper use. Okay, Dr. Ruby Singh changed her ethinyl estradiol to 35 microgram. Okay. Who else has options? G. You want to give her high dose? 50 microgram. 35, yes. Dr. Husni. Any more takers? Any more givers for the answers, or you not takers? Just 20 more questions, guys. We'll be done. Give me half an hour more, okay? I know in India it's almost 1. Okay, most of you are not answering now, so I'm just gonna write G here. I'm sorry, not G, F, which is correct because you have to change over to 35 microgram of ethinyl estradiol. Okay. This was regarding, yeah, so this was just because I wanted you all to read this. So I have shared it on the group already. It is regarding the combined hormonal pill and improper use. Just go through it, it's important. And this is the algorithm for unscheduled bleeding. What do they say? They say first is that you have to less than 3 months since starting the method, all of the above checked and confirmed. Thereafter, a genital examination and further investigation, biopsy scan are not required unless requested by the women. So you reassure and you arrange follow-up. See, it's given there. Okay. And if it's more than 3 months, then you do a speculum examination. All of that is done, normal findings. Then you can change the estrogen. Okay. Oh, it's here. The slides were mixed up. This is subfertility. So 24 months is the clincher. And remember, they've not given you age here. Excuse me. See, very good. It's unexplained infertility. Correct. I'm really happy that you're answering this well. This is C. Next question. Okay, what do you guys think? Question number 34. Correct. Dr. Ruby, see, she is just having mild endometriosis, right? So you can give it for another 11, like do expected management. Okay. Next question. Sorry. Yeah. So they're basically asking how many embryos can be transferred. The age, look at the age, 36. This table has to be a bit bad, guys. As to how many embryos are being transferred. Single embryo, double embryo, triple embryo. Triple embryo is not there in the guidelines, so it's choosing between single embryo and double embryo. And she's 36 years old. Okay, you're saying F. I don't know why I've written it as G, it is F. Yeah, so you all are correct because she's 30, less than 37, single embryo transfer. It's a first cycle, right? No, if she's going in for a second full cycle, guys. So if one or more top quality embryos are available, then yes, single. If no top quality are available, then double. So guys, this actually question is from the old guideline, and this is the newest guideline, which says that when there's a top quality embryo, you give second. When there is not a top quality embryo, you give double transfer. Okay. Please remember. Is this clear? Top quality single, yes. Okay, great. Moving ahead. Informed consent. Yeah, you have to take informed consent. What are the other people saying? Do you think anything else that we need to take into consideration? Autonomy. Okay. Okay. So here, guys, she is going for a procedure, right? So it's an informed procedure. Autonomy is correct just for the fact that okay, she can choose, but why is it specific in this question, right? She has the autonomy to refuse it, but she is being told about the procedure. She's being told about the alternatives, the risks and the benefits, and she and time to decide whether to opt for the procedure. But what is the next step that we have to take? Right? We have this is not autonomy. This is informed consent because in informed consent, this is what we do. We explain about the procedure. We give alternatives and risks and benefits, and you give time to decide. This is the classic definition of an informed consent. Okay, guys. So, before we move on to the next question, as you can see this, okay, this link that our team has shared. This is a special group for you all where we will be sharing all last minute revisions and all the data that I said that I would share in the group. Those who are not there in it, please feel free to get added. Share it with your friends who are giving with the part 2 exam. Just not something that will be too crowded, just whatever is important. And if you all have any doubts, you all can ask us on that group. Okay. Next is the patient developed complications post-operatively and claimed that she had not been informed about the risk of procedure. The doctor says that the risks are normally not discussed according to the standard or the practice in the unit. All of this comes with a very classic thing. I've taught you all in this Montgomery. Very, very good. Amazing, guys. The last one, a forceps delivery is performed and a 3.9 kg baby is delivered. Delivery was complicated by shoulder dystocia and the baby developed herbs. The mother claims that she was counseled about shoulder dystocia, however, not complication of Erb's palsy. This is again classic what? Montgomery, correct. This is what actually happened with the Montgomery hearing, which was before, I'll just show you all this. This is from my session. The seriousness of the condition is understood, tell about benefits, tell about complications, alternative available. Doctors now have a legal as well as professional duty to ensure that patients are aware of any material risks involved, how small it might be. You have to tell the patient. And this was what was Montgomery versus Lancashire. It said that Mrs. Montgomery was a primary gravida with type 1 DM who booked under a consultant-led care in 99. She was noted to have a large baby with her 36-week scan and was induced at 38.5. Although she expressed concerns about the size of the baby, the risk of shoulder dystocia 9 to 10% in diabetic mothers was never discussed with her. Her consultant who advised a vaginal delivery defended her practice, saying that in her estimation, the risk of a grave problem for the baby arising as a result of shoulder dystocia was very small. The baby was delivered by forceps, but this was complicated by shoulder dystocia, and there was a delay of 12 minutes between the delivery of the fetal head and the body. Her son developed severe dyskinetic cerebral palsy as a result of hypoxia during delivery. This ruling has updated the law to reflect current clinical practice and improve autonomy and the patient-focused relationship. This is what happened in Montgomery, okay? So, very classic 2 questions of Montgomery ruling. I'm glad you all could answer this well. Please, guys, I've not included questions on statistics, but autonomy, ethics, governance, teaching, and teaching also I've not included in this, unfortunately. Teaching and statistics is something that you all have to revise because I had done that mistake of not revising statistics for my exam because I had fallen short of time and I actually couldn't answer a couple of questions which I knew but I could not recollect because I had not revised it. Okay, so please, guys, just go through a statistic. Part 1 notes are also enough. They don't ask you any different higher level statistics. It's the same thing that they ask in part 1. Okay, this is from an old talk actually, precocious puberty. But I thought you all might know you should revise precocious puberty because again, something that we don't really see often and not comfortable with. Dr. Manikam is saying F. Okay, great. Waiting for other answers. Okay, so Dr. Manikam is the only one who's answered and she's correct. It's F, anastrozole. This is classic McCune-Albright syndrome. Why? Because if you'll have learned precocious puberty, there is hyperpigmented macules in certain parts of her body with features of axillary and pubic hair as well as breast enlargement. Hyperpigmented macules is F, anastrozole. Okay. Next question. Where are you, all of you, not very comfortable answer this question? It's a talk from 2012. It's an old talk, but it's important. Important concept, precocious puberty. Central precocious puberty, peripheral precocious puberty. This is also very classic. What is this, guys? Dr. Manikam has answered C, glucocorticoids with mineralocorticoids. This is, can you at least tell me the diagnosis, guys? What is this? If not the treatment. This is CAH, congenital adrenal hyperplasia. This is classic CAH, guys, with salt wasting crisis. Am I right? Yes. So Dr. Manikam was absolutely correct in saying that the treatment is glucocorticoids with mineralocorticoids. Yes. Dr. Pradeep, Dr. Hassan. Last question, 41 number, 14-year-old girl, referred for primary amenorrhea. Deep voice with a lot of acne and has been harassed in school because of excessive hair on body. So this talk says, yeah, so this is again, so this is an old talk, right? So here they're saying that you give hydrocort for NCCH. This is actually non-classical congenital adrenal hyperplasia, right? So I would have gone with cyproterone acetate as well because it is what we use for NCCH and it is decreasing hirsutism, decreases the androgen. I would have gone with L for this. Okay, not hydrocortisone. In that talk it is given though it's hydrocortisone. Okay, this is it with hydrocortisone. Why they're saying hydrocortisone alone to allow attainment of normal adult height. This is the table from that talk. So I can take a screenshot of it if you want. Not something that they'll often ask you because precocious puberty is not often seen. But I think this talk is something we have not studied, so I wanted you all to know about it. Infections. Dr. Ruby, you said you didn't like infections, right? I start answering this now. I used to love answering infections because it's all antibiotics. And to be honest, in my exam, so in my exam, I had PID questions. I had an EMQ on PID. And yeah, I had goofed that up. One, because I was like very confused between what was the correct answer or not. 18-year-old woman presents with vulval swelling, which is, she thinks has grown slightly bigger and is painful. She's apyrexial and not well. This vulval swelling is at the junction of a labia minora and majora, likely to be a Bartholin's. Flucloxacillin, correct. For a Bartholin's, they said give flucloxacillin. Amox is something that actually we give in practice. Completely agree with that. But the key that they've given for this is flucloxacillin. A 20-year-old woman has been admitted to the gynecological assessment unit with lower abdominal pain and discharge. Lower abdominal pain and discharge. What is your clincher here, guys? A clincher here is that she has what? She has pelvic inflammatory disease. So how would you treat for pelvic inflammatory disease? Yes, Dr. Hosni says G, you're right. You give ufloxacillin, metronidazole, and doxycycline. This is, yes, you're right. All of you are right. Very good. Next question. A 56-year-old woman, vaginal hysterectomy, anterior repair, 48 hours ago. Complaining of lower abdominal pain, feeling unwell and borderline pyrexia. Here we would want to give, this is a post-operative complication. Broad spectrum antibiotic has to be given. So what is the broad spectrum antibiotic that we commonly give? Your Dr. Hassan, Dr. Husni is saying B. And both of them are right. We give cephalosporins with metronidazole. Next, a 48-year-old woman endometrial ablation carried out 24 hours ago and readmitted with swinging pyrexia. Again, a post-operative complication. No dear, you would be giving cephalosporin and metronidazole. The college doesn't really like amoxiclav, they do not even give it for surgeries. They prefer giving cephalosporins for cesarean surgery as well. So cephalosporin plus metronidazole, it's the best broad spectrum antibiotic. We need to cover negative also, right? That is why metronidazole is important and anaerobic, not gram negative. I'm sorry. For anaerobic, we like metronidazole. So again, here it's B. Last one, 47. Now, a clincher here is that she's already gotten a broad spectrum, which is cephalosporin. However, even that of her pyrexia has failed to settle, even after 24 hours of intravenous therapy. Would we want an MDT on this? Hint. Dr. Hassan has gotten my hint. I'm happy. Correct. Dr. Pradeep as well, Dr. Chetty as well. We would want to discuss with the microbiologist that why we want, yes. So again, the people there like MDTs, right? So they prefer involving someone who has a better knowledge about what is going wrong with the patient, right? That is why microbiologists should be involved. We do that in our hospitals as well, right? Okay. Last question, guys. Hang in there and answer this well now. Come on. Oh, this is consent now. Dr. Ruby, can I give you a hint? That she's 16 and Fraser is below 16 or above 16 or above below 18. What is it? Yeah, it's below 16. Fraser is only taken when it's below 16. So correct, you're a G. Next question, guys. This is right. J, informed consent. 16 is the word here. You have performed the first of delivery for fetal distress in the second stage of labor. The outcome of the fresh stillbirth case was referred to the coroner, who is now asked for the medical report. So none of you are answering. So in this, what happens is that this is coming from a coroner. And what they say that when it comes from a coroner, you have to release the information that they're asking for, because it's statutory to release that information. Right? So this is K. Yes, release the information. Okay, so this is something that no need of patient permission, no need of husband permission, no need of hospital permission. Just release the information. Okay. A 15-year-old woman is seen in the genitourinary medicine clinic with vaginal discharge. How old is she? 15. Okay. And lower abdominal pain. She presented with her 19-year-old partner who is also symptomatic. You suspect that she has an STI. So here we get she's 15. So that's the hint that I'm giving you all. Why would I inform the social worker, Dr. Sama? Oh, treat but inform police. Why? In India we would, but not in the UK. N, seek permission from no. So if I'm not mistaken, you're not getting the concept of Fraser, uh, Fraser guideline and Gillick competence. Okay. So Fraser is saying uh, that below 16 years of age, if the woman, if the girl, she either comes for contraception or termination of pregnancy, or even for treatment of STIs, if she is understanding what is wrong with her and she understands the implication of it and she's consenting for it, then she's eligible for the treatment. Yeah. So P, yes. Yeah. So um, I agree. So as I was reading the explanation that has been given for this, I had this dilemma as well because the explanation sounded a little ridiculous. So I'm just going to quickly answer the last one so I can show you all the explanation. It's from Justin Konje that I've taken this question. Please answer the last question and then we'll have a discussion, Dr. Hassan. Even I understand that because 21 and if they're similar in age group, it is not considered difficult. But since here there's almost an age gap of 4 years, it's actually comes under an offense. Yeah. Yeah. So when it's older, it's illegal. But when it's the same age, then you'll have to do the Fraser and the Gillick thing. Oh, you all are right for the eighth one. Now I'm just going to quickly show you all this. You all were right for obtain consent, release information because as I said, this is the same with coroner's autopsy. The parents or the relatives has nothing to say for to a coroner's autopsy. The same thing for a coroner's request. So what they're saying is that, however, common sense for this question, where the answer was, so what they've done is they have written P here, okay, and they have said P is treat after ensuring further competence and encouraged to tell parents. This is wrong because this is P. 8 is P is actually committing a criminal offense. Okay, so these are explanations are wrong here. So this is however common sense in most case will prevail and he will not be reported to the police is I don't think so should be here in a book. So it's correct that you all were right actually, guys. Thank you for pointing it out. So you have to involve the police in this because she's 15 and the boy is what, 19 or something? Yeah. Okay, she's 19. And in this also it's the same thing, 14-year-old, 20 years. Okay. So to be honest, for both of them, I would say it's O, police. Okay. I all understand. Do you all have any doubts regarding this? Any questions? I will also share a link about the Fraser guidance and the Gillick competence, so you all can understand better regarding it. I'll put it in the group, so you all can quickly go through it. Not a major read, just a small thing that I actually read to understand it better. Another thing that I want to tell you all is I'm not aware how many of you all are actually preparing for this exam, the one in the January. One, I know Dr. Ruby and Dr. Chetty are, but the ones who have attended the free session today, I might not know y'all. And so, so I would just like to tell you all that this is the time for revision. Whatever you all have read is you have to recall, you have to relook. And revision doesn't only mean looking at your notes, but it also means solving questions as we did today, and also specifically paying attention to the ones that go wrong. Don't just blindly read the explanation, go back to the guideline and solve it. Okay, use whatever time. I understand that all of us are working, we have a life other than giving MRCOG, but whatever time that you have in your hands, only and only concentrate on giving and giving 100% in revising and solving. Okay, so I hope today's session was helpful to you all. It went on for around 3 hours, and I hope I could do justice to your doubts. Please feel free to join the group, and it's a free group. We'll be sharing whatever is important in the group. And another thing is don't get overwhelmed, because I remember the emotion I was getting before I started my solving the paper. I was like, I'm not prepared for this, but I just had to give it because I was like, okay, I'm here now, I'm doing it. I remember I came out and I told my mom that I'm either going to pass or I'm either going to fail on the border, and I did pass. So I'm thankful for that. So don't worry, it's a difficult exam. So the college filters through this exam. Okay. So keep solving, keep revising. Thank you, everyone. It was, first of all, nice to meet all of you. And I hope all of you don't be scared. I know it's scary. I'm scared for you all as well, but I'm not going to show that. I'm going to be there with you to help whatever doubts you'll have. And it's very nice meeting all of the new people that I had today. I hope you'll clear and pass with good colors. And whatever your outcome is, please do let us know. We'll be in touch with you all through the group. Thank you, Dr. Paul. Thank you, Dr. Ruby. Good night. Now it's late. Sleep well. Have a great